Welcome to the first episode of ASNC Health Policy 101, where we'll answer the questions that members often ask about how legislative and regulatory rules come to be, how they impact reimbursement and practice management, and how you, as an ASNC member, can participate in important advocacy efforts. I'm Randy Thompson, President of ASNC and longtime member of ASNC's Advocacy Committee. It's my pleasure to host this video series, and I hope cut through the confusion and myths that can limit our ability to be effective advocates for our patients, our practices, and our profession. In this first episode, we're going to tackle a question I get asked all the time: how do physicians, and in particular nuclear cardiologists, get paid in the United States? Ultimately, the Centers for Medicare and Medicaid Services, or CMS Medicare, has final authority to decide the relative value for a service, procedure, or test. However, the American Medical Association's RVS Update Committee, or RUC, plays a crucial role in recommending relative values for every single medical service. And it's with the RUC that physicians can and do make a difference. The RUC is a group of 31 physicians who advise Medicare on how to value physicians' work. RUC members recommend the relative value resources and the direct practice expenses required to provide each medical service. The RUC's evaluation of each service is given to CMS, which then uses the information to develop the relative value units, or work RVUs. CMS usually, but not always, follows the RUC's recommendations. These RVUs are the basis for Medicare payment amounts assigned for each medical service, and of course, private insurance companies usually follow. The three components that make up RVUs: there's physician work, which is involved in the service, how much practice expense or resources are required to provide the service, and the professional liability insurance required for the service. The medical specialties evaluate new or revised codes. They also may reevaluate current codes. This process is referred to as surveying a medical service when there's reason to believe the code is misvalued or perhaps the code is just new. Usually that means there's a question as to whether the current assigned payment for service is too high or out of date. So for example, cardiac PET codes were reevaluated in 2018 because of the volume of PET services experienced a high rate of growth in the years prior to 2018. It had also been decades since the codes were last evaluated. There'd been quite a bit of change in the way PET was performed over that time. So ASNC and other societies took a proposal to the AMA CPT editorial panel. The codes were revised and new codes were written, and that triggered a RUC survey, which was then carried out. The RUC uses the survey data and other established relative values to recommend time and relative work values for each service. The survey process is pretty straightforward. The AMA RUC develops a survey tool, and the medical societies send it to physician members who perform the service. It's worth noting that societies are not allowed to send surveys to non-members. The survey questions are aimed at helping gather data that accurately represents the time, intensity, and complexity that is required of a physician delivering the service. The survey should capture the typical or most common, not the most difficult or least difficult patient. It's important that the surveys are completed with honest, clear input from practitioners like us who are performing the procedure and whose value is being reevaluated. That's where you and I come in. As physician members of ASNC or sister societies like SNMMI, ACR, or ACC, our responses to the survey will frame the RUC's discussion about how much the service is worth. That means physicians like us are the source of accurate data for the RUC. And some other spaces, there are registries which time procedures, for example, TAVR. Those timed registries are not the source. The surveys that we're completing are the source of time and effort. After the survey data is compiled, the 31 physicians on the RUC meet. Medical specialty societies, including ASNC, present data on clinical vignettes that illustrate the time, intensity, and expertise required for each service. We also answer any questions the RUC members have about the physician's role in each service, and specifically what the physicians are doing with the recommended time. The RUC uses the data from the surveys, thus the more data the better, to agree on a number of relative value units to assign to the service, and then delivers that valuation, the full RUC recommendation to Medicare. Anyway, Medicare then uses the recommendations to establish the official CMS value of physician work in annual proposed or final rules. Remember the equation? Sum physician work plus practice expense plus malpractice insurance. That sum is then multiplied by an annual conversion factor to calculate payment. The change to any part of this equation will affect the final payment for the procedure or service. The single most helpful thing you can do is to be on the alert for surveys. If you receive one, respond accurately and promptly. Anytime there's an active survey to assess the valuation of a nuclear cardiology code, ASNC will notify members to be on the lookout for it. We'll ask you to watch your email and your spam folders for a message from the AMA survey tool called Qualtrics, Qualtrics, Qualtrics. Believe me, ASNC will remind you to complete the survey. Now, fill out the survey may sound obvious, but you'd be surprised how few people respond to surveys. You might ask, why doesn't ASNC push us more during the survey period? That's a great question. The reason is really important. During the period when a survey is being fielded, medical societies can only tell their members that a survey is being distributed and ask them to complete it. The AMA does not allow us to say anything more for fear that communication will influence or taint the responses. The term that's sometimes used here is lead the witness. That, of course, comes from courtroom dramas on television and movies where one attorney will jump up and object that the opposing attorney is leading the witness. But just like attorneys cannot lead witnesses, medical societies like ASNC cannot tell you how to fill out a survey. It's supposed to be your honest appraisal of the effort and work and time that something takes. First, make it your priority to complete and return the survey. The survey must have a robust response to be a fair representation of physician practice patterns in different practices and regions of the country. I know you're busy, but if you get a survey, please move it to the top of your to-do list. It's vitally important that you fill it out and return it in the requested time frame. Second, really think through your answers to each question. The survey typically asks about the time it takes to perform the service, the technical skill and physical effort required, and the mental effort and judgment required due to the risk. I've had colleagues in the past who were rather poor about judging how long something took. I remember one in particular who would frequently call his medical assistant and tell the medical assistant to go ahead and room the patient who's waiting for him to be seen in the office. He was just going to do a quick coronary angiogram, will be there in 10 minutes. Well, it takes longer than that to do a coronary angiogram, and he had to walk 7 minutes from the hospital over to the office. He had to change, he had to talk to the patient's family, and so that's not the way to fill out a survey. You really want to be honest and very realistic about how long something takes. It's not a race. It's not, you're not my show to do something quickly. Just be honest about it. And finally, be aware that the survey will also ask you to choose from a list of comparative services. Choose the one that is as close to the service under survey as possible. It should be a service you're very familiar with. You may choose others you're less familiar with if those are closer to the survey code. The idea is to help the RUC understand if the service requires the same amount of work, a little less work, or a little more work than the service under survey. You'll do this for each part of the survey and for each code being surveyed. In fact, codes are usually surveyed in families, so there'll be several codes that are similar. Here's some guidelines to keep in mind as you answer each question. Consider your interpretation of both highly complex patient cases and more straightforward cases. Aim for a response that averages your interpretation time on the whole. It's important that your estimation encompasses the variety of patients you see and interpret reports for. The RUC is looking for your most typical patient, not your highest or your lowest, as I mentioned earlier. Think of all the required components of a service. You want to give the RUC a full picture of your work. Pre-service, during service, and post-service. In nuclear cardiology, for example, we often get asked questions by our techs, our nurses. We have to make decisions, and all that counts in the overall work of your day. Now, while ASNC is not permitted to instruct you on how to fill out the survey, we're always available to answer questions about when a survey is active, when to expect a survey, and any other questions you might have. Do not rush to finish completing the survey without considering all the work you do, especially your oversight and responsibilities for any radiation protection or assuring a quality image. Be sure to watch the AMA video on how to properly complete a survey. We'll put the link on the screen and on asnc.org. There's a very good YouTube film on this. I hope this fills in some of the blanks about how you get paid. Stay tuned for the next episode of Health Policy 101, where we'll tackle the topic of APCs, or ambulatory payment classifications, and how payments in the hospital outpatient department are reimbursed.